Good afternoon, everybody. Thank you to the Minnesota Dental Therapy Association for inviting me. I'm really excited to be here today, and it's been a very good program so far. I started dental school in 2010, so the cohort with my class was the second class, and so it's been very, very exciting kind of seeing how the program's evolved and even getting my first few referrals from dental therapists. So excited to be here. Our topic today is going to be imparting wisdom, surgical and non-surgical management of erupted and impacted third molars. So Katie kind of touched on relevance. I'll kind of, I have a slide kind of going over scope, especially with dental therapists and advanced dental therapists, and how you can be involved in management of wisdom teeth. I won't go into the introduction since a nice one from Katie. I'll start with a brief outline of my presentation. I'll start with some background on third molar development. We'll move on to appropriate timing of a management decision for third molars. We'll discuss the various management options, including surgical management and non-surgical management. We'll touch on anesthesia options because I'm sure your patients will ask, or Mike, I have to be asleep, or you know what kind of anesthesia we'll have. Post-operative care. Some folks might drive a while to come see me and might feel better going to your office. We always see our patients for follow-up if necessary, but sometimes we know they go back to their referring dental home first, so you might be managing some post-operative care issues or even seeing some post-operative complications, so we'll touch on that as well. Is the sound okay so far? All right, in the back, if I get cut out, just put a hand up like a mic and I'll get the hint. So, some relevance to dental therapy here. So I did some homework before I came and pulled up the Practice Act, and dental therapists can dispense and administer analgesics, anti-inflammatories, and antibiotics, all very key parts of managing pericornitis and any dental pain, obviously. They are also allowed to perform dressing changes, which we'll talk about, remove sutures. Most of the sutures I use are dissolvable, but sometimes they don't dissolve quickly, and they might come to your office and say, can you just get that out? Well, yeah. Additionally, advanced dental therapists can formulate treatment plans, and this is where I'm getting referrals from advanced dental therapists now, and can perform non-surgical extractions of periodontally hopeless, grossly mobile permanent teeth, and that would theoretically include wisdom teeth. I don't know how many people have taken out a wisdom tooth, but it's in the statute, so. First, I want to frame our discussion a bit, too. Some aspects of third molar management are pretty black and white, but others are quite gray. So keep that in mind when thinking about third molar management, because all of our decisions are ultimately individualized for each patient, right? If it was very black and white, my presentation wouldn't be an hour long. We're going to touch on a lot today. No simple rule exists in deciding third molar management strategies, and I'm also acutely aware that not all third molars are referred for management. A lot of wisdom teeth are managed in the dental home, which you are part of. A lot of questions about wisdom teeth that I'm sure many of you have thought of and are hoping to get answered today, like, number one, do my patients' wisdom teeth need to be extracted? Or can they keep them? You might get that question a lot. Well, can't I just keep my wisdom teeth? And hopefully by the end of this too, you'll know when you should refer a patient for evaluation of their wisdom teeth. So moving on to some background first. The wisdom teeth are the last permanent teeth to develop, developing in the age of wisdom, age 17 to 21. Someone actually did ask me that yesterday, I believe. Why are they called wisdom teeth? And I told them, and they're like, oh, okay. It's a line from the AAOMS informed consent video that we always had to play all of our patients in dental school. I don't know where that came from, if that's true or not, but that's what I'm going with. So third molar development progresses through these stages on average, right? We've all seen a lot of variability in this. going from bell to cap to root development to completion of root development. But by age 12, you're starting to see that on a Panorex. Highly variable, though. Wisdom teeth are the most commonly missing teeth in the mouth. These stats vary widely, but 5 to 30% of folks are missing at least one wisdom tooth. That, of course, is because a lot of these studies are highly dependent on the population that they study, correct? Third molars, then next congenitally missing maxillary lateral incisors, and then the mandibular second premolar would be the next most commonly missing tooth. Why this is, there's several answers. Is it familial versus sporadic? Yes and yes. And does evolution play a role into this? Probably. We're evolving towards a smaller jaw size and towards missing more and more wisdom teeth. They're also the most commonly impacted teeth. An impacted tooth is just simply a tooth that fails to erupt either in the expected window of time. I didn't put those arrows on there just in case you're wondering. Either due to inadequate space in the dental arch or because the tooth is coming in the wrong direction. And so you can see in this photo on the bottom, that's going to be because of the wrong positioning or maybe inadequate space for 16 there. Well, why are wisdom teeth frequently impacted? Well, there are several hypotheses for that. One would be the differential growth rate of the mesial versus the distal root. So if you can imagine here, two roots growing. If one starts to grow faster than the other, that's going to tip a tooth. There could also be lag between tooth development and jaw growth. So a jaw may grow slower than the tooth grows, so it may get impacted before there's enough room to accommodate it. Or just an absolute tooth mass arch length discrepancy due to insufficient jaw growth. And that is commonly being seen now because our diet is so soft and processed. Our jaws are not growing to fully accommodate our teeth. And then the attrition theory, also diet related. Our diet is so soft that a lot of the interproximal wear that folks used to get from eating a less refined diet just doesn't exist anymore. So if you can think of just getting a fraction of a millimeter from the interproximal surface of all of our teeth, how much space that would create, right? If we just need an extra millimeter, that very distal, to get a tooth to come in, that can make a huge difference. And I wanted to touch on classification systems. There's several because classification is important for discussion amongst professionals. The first classification's rarely used clinically. This is more textbook if you in dental school learning this. It's a Pell-Gregory classification. Class A, B, and C talks about the vertical dimension, and class 1, 2, and 3, the horizontal dimension. The more commonly used classification system that we would use amongst each other as professionals is the Winter classification. You might not have known the name of it, but you've certainly heard of mesioangular or vertical or horizontally impacted. The most common is the mesioangular here down at 4. That's about 45% of wisdom teeth. The next then being vertical in box 1, then horizontal and distoangular. And then much more rare being transverse and inverse. Actually have seen them. And then another is ACDT codes, the current dental terminology codes, important obviously for all of us to know. Soft tissue impaction, the D7220, partial bony 7230. And then I think what might be surprising to many people is that completely bony actually isn't completely bony per the CDT terminology. It's most or all. So theoretically 50% or more, right? And so it doesn't need to be completely covered in bone to be a completely bony impacted wisdom tooth, which might be surprising to some folks. Next, I want to go ahead and start touching on timing of a management decision. When do we decide to pursue management of these wisdom teeth? Well, this begins in the dental home. very few people come directly to the oral surgery office. I think our last group meeting, probably 98% of our patients come through referrals. Only 2% were self-referred. I think the most common scenario that I see might be someone that just moved back to the Twin Cities from college and they finally have dental insurance and they just didn't even think of going to their dentist first. They just finally got that dental insurance and they wanted their wisdom teeth out, so they came right to the oral surgeon. But usually they're coming through their dental home, seeing you or your collaborating dentist first and hygienist. And so the AAOMS, that's our Professional Association on Oral Surgery, has a white paper on third molar management. And they said this in terms of timing of management decisions. So ideally, our management decision should be made before the middle of the patient's third decade in order to maximize positive outcomes and avoid known risks and complications. And so we'll touch on many of these risks and complications, but middle of the patient's third decade, so around age 25, we should have had a plan in place by then. And that's because the role of age has a lot to do with complications, recovery, healing. Younger patients have less developed root systems, putting in adjacent structures at less risk. They have lower risk of post-operative complications, some of which include fracture, infection, nerve injury, post-operative periodontal issues, temporomandibular joint disorder, and sinus complications, and they heal faster. Younger kids heal so much faster. The difference between an 18-year-old having their wisdom teeth removed compared to a 35-year-old, it is real. And so if 25 is kind of that, I don't want to say cutoff because that's pretty black and white, but what might be the best time before age 25? Well, the answer to this is kind of complicated by the high variability in third molar development. And so if we're going to use something like a Panorex, this is the cartoonized version of a Panorex, we're looking at root development. And so I think I might have jumped ahead there. But first, finding out if they're symptomatic or asymptomatic. If they're symptomatic, we're, if comfortable managing that in your office, manage it in your office or refer, regardless of age, if they're symptomatic. Especially persistently so, and more than just, gumming pains from tooth eruption. The next category would be if the patient's asymptomatic and disease-free, we're going to guide that referral by root development over absolute age. And so I think on the next slide I kind of touch on that. And so ideally our referral timing for this set of circumstances is in that 1/3 to 2/3 root development based off of the Panorex. And I kind of liken it to a Goldilocks situation where in terms of ideal management, you could maybe be too early, too late, or just right. Now, in reality, no one's really too early or too late. But if you're talking about ideal, when's the best time, it's guided off of this. And that's because, I just saw a 15-year-old who's looked like this. So if you're waiting until 16 or 18, we missed that boat already. I've also seen 20-year-olds whose wisdom teeth look like this. And, and there are circumstances where we would get wisdom teeth out regardless if some other circumstances, and I can touch on those, like jaw surgery. We need healed bone in that area, so we might go after wisdom teeth that have no root development. But the truth is surgery is easier, recovery then is easier, and people bounce back quicker when the procedure is done in that ideal time frame. And so now that you've recognized that it's time to potentially refer a patient, let's talk about the referral. I think this is probably the most underutilized part of the patient record, because it is a part of the patient record, right? The referral is the bridge between your office and my office, and it's a great opportunity to continue the discussion or conversation where you left off. It's a great time to put this patient's got caries on all of their wisdom teeth, or there's periodontal disease. Because a lot of times by the time someone sees me, especially like this time of year, some people have been waiting 2-3 months because summer was busy and they didn't have an urgent condition, so they waited several months. Many folks don't remember why you sent them. And so using the comment section really helps, especially when it's someone that's beyond age 25, where we really do want an indication to remove them. And so, you know, I might have the Panorex, but I don't necessarily have your bite wings to see the caries that's on them. And so just being clear with, obviously we'll do an exam, but it's a great opportunity missed if there's nothing on the comment section. And so this is, we were talking over lunch, I believe, or one of the earlier breaks, you know, when you send a patient to consult, you don't get to sit in and listen, and so that's one benefit to this discussion today. You kind of get to be in, you know, an OMS consult today and know what goes on and what gets said, and so it can go a variety of ways, depending on what they're coming to us for, what their age is, their medical status. We might do a separate consult appointment or a combined consult with the intent to do surgery as well. And during that consult, we'll obtain a thorough medical and dental history. As we've touched on, patient age matters, medical comorbidities, presence or absence of symptoms. We'll do a comprehensive exam, both clinically and radiographically. I'm assessing functionality of these teeth, presence of absence of disease like caries, periodontal disease, history of pericornitis, and risk factors too, because that makes a big difference. Is this patient's mouth already full of restorations? And then a radiographic one, of starting with a panoramic radiograph. That is our screening x-ray of choice, but also having the availability of CBCT. This helps us look for cysts, tumors, proximity to important structures like the sinus, the inferior alveolar nerve, and the condition of adjacent teeth. And so what are some of the common third molar management options? Well, removal or extraction is one of them. Intentional partial removal or coronectomy. How many folks have heard of coronectomy before? Okay, so about a third or half. I'll touch on that. And then the last one is more or less keeping your wisdom teeth, retention with active clinical and radiographic surveillance. And so which route we pick, I'm not the first person to have this slide already. I think you had it too. But a lot goes into picking the right option. One is the dentist's expertise or the provider in the dental home, but then also the specialist's expertise, the scientific evidence, and the patient's needs and desires. Some folks think taking out 4 teeth at once is too much. Some will only insist on 2 at a time. Some don't want to leave any of their wisdom teeth, even if there aren't absolute indications for removing them. There's a lot that goes into patients deciding to move forward with treatment, and so that is a factor here in guiding our decisions, in addition to the dentist's expertise and the scientific evidence. And so Amos put out a position statement on third molar management, and it goes as this: predicated on the best evidence-based data, third molar teeth that are associated with disease or at high risk of developing disease should be surgically managed. In the absence of disease or significant risk of disease, active clinical and radiographic surveillance is indicated. And so I think many people think, most oral surgeons just think all wisdom teeth should be removed. And that's not the case, and that's the position statement of our association. There are wisdom teeth that you can keep. And we'll touch on which ones those are. So let's talk about surgery here as a management option for wisdom teeth. The first of the surgical options we'll talk about is removal. And there are many indications for removal, and we'll kind of go through this list here. The first is pericornitis. And pericornitis is an acute infectious and inflammatory process of the overlying gingiva on partially erupted wisdom tooth. It's characterized by pain, swelling, redness, purulence. Has anyone not seen a case of pericornitis yet in their office? Yeah, pretty common. It's caused by masticatory trauma and then probably propagated by food and the bacterial feeding off of that underneath the operculum. And these bacteria are obligate and facultative anaerobic bacteria. And so treatment first begins with local measures, improved hygiene, irrigation with a monoject syringe. Oftentimes that's enough to resolve the issue. Antibiotics if necessary, especially if they're in significant pain, have trismus, if it's starting to spread beyond just the area of the tooth. A nice quick fix actually is simple removal of the opposing tooth. There are many dentists who enjoy and don't have any issue removing erupted upper wisdom teeth. They can be quite a bit easier compared to their lower counterparts and can cause immediate relief if that's caused by occlusal trauma from number 1 or 16. And then obviously removal of the offending tooth as well. I don't jump into removing that tooth though in the middle of an acute pericornitis, and that's because the tissue's red, it's inflamed, it's bleeding, and you also have the lingual nerve. So if tissue tears easily, you better hope the lingual nerve's not in it, especially if you're on that aspect of the tooth. So I generally like to resolve the acute infection before that. In the antibiotic of choice for this, if we're thinking, anaerobic bacteria, I go with Flagyl. I've had many patients sent to me already on amoxicillin, and they're getting better. But I often use amoxicillin post-operatively, and so a back-to-back prescription of the same antibiotic, if I can avoid that, why not? Orthodontic considerations are common reasons to remove wisdom teeth, and I'll touch on these here on separate slides. In this image, you can see the lower second molar is unable to erupt into its proper position, in part because of the presence of that wisdom tooth. And so in this situation, we would remove 17 and then upright 18 and allow the orthodontic treatment plan to continue. Not necessarily removing the other 3 wisdom teeth at that time. These are pretty underdeveloped. I alluded to this, but the possibility of someone needing corrective jaw surgery in the future or orthognathic surgery. You can see here in these diagrams on fixation, the hardware goes right through the area of where the wisdom tooth is. So you can imagine we want good quality bone there. And most surgeons will remove wisdom teeth at least 6 to 9 months before planned orthognathic surgery so that the area has had adequate time to heal. And this is a common one, and this really it belongs in the myth category. Do wisdom teeth contribute to late anterior crowding? This has been looked at many times with systematic reviews, failing to show direct cause and effect. Are there instances where this has happened? I'm sure there are. But in terms of looking at population level, it's thought that this is more of a temporal coincidence rather than a cause and effect. Is it worth having an argument with your patient? Or in my case, having someone question the wisdom of their referrer? Of course not. I'm not going to say, well, actually, the science says of course not. But we as professionals can know that maybe we aren't going to scare our patients into telling them they have to get their wisdom teeth removed because of this. There's too many proven reasons to get your wisdom teeth out. We don't need to harbor on this. So periodontal disease. So a common indication for removal of wisdom teeth, especially in adulthood. But the prevention of periodontal disease in the under age 25 category, and I'll touch on why that is. And so the Amos white paper on third molar data, and I'll provide a link or really show you where to find a lot of these AMOS materials. Found that the presence of impacted third molars adversely affects the periodontium of adjacent second molars. The presence of visible third molars is also associated with overall elevated levels of periodontitis in the mouth and that of adjacent teeth. And using probing depths, the presence of 4 to 5 millimeters or greater and or bleeding on probing should be recognized as possible predictors of future progression of periodontitis. And so that can be an indication for removal of wisdom teeth. Now, removal of impacted wisdom teeth can not only cause post-operative bony defects, but in someone with active periodontal disease, they already have a bony defect. And in some folks, this defect will heal, and in other folks, it won't. And the major predictor of that is age at time of removal. And so removal of wisdom teeth prior to age 25 is much more favorable for bony infill on the distal of those lower second molars. After age 25, folks are going to have the bone loss that they have. It's going to be much more accessible for a hygienist to get back there and scale. It's going to be much more accessible for a patient to floss without that, horizontally impacted wisdom tooth right up there. So that defect will be maintainable instead of continuing to progress if the tooth was still present. Additional considerations or predictors of large postoperative bony defects would be the initial size of the defect, the contact area between the second molar and the third molar, which is kind of a corollary to the last one where it mentions horizontal or mesioangular impaction, root resorption on the second molar, or a large pathologic follicle of the impacted wisdom tooth. And so treatment options of these defects, it's an area of active clinical research, and I don't think there's a clear standard of care here, other than that maybe the standard of care is currently that oral surgeons generally don't treat that area to encourage any additional bony infill. The current literature is mixed. There's some strong prospective split mouth designs, but generally the patient size and follow-up's minimal. Certainly aren't needing to consider doing anything in folks under age 25. Their body will naturally fill that in to an acceptable level. But treatment options that are being investigated involve immediate grafting. Like I said, not commonly done by oral surgeons. It's just not predictable. You would need to have your oral surgeon scale and treat, and because a bone graft's not going to take to calc-lined, distal root of 31. It's not going to do that, and that's a waste of $600 right there, or whatever they're charging for bone grafting. But an area of active research. And so caries, the most common disease in humanity, right? So this is a thing we all see, right? Which is unfortunate, and I think what many of us hope to avoid. And so I was telling Katie about this, a cautionary tale here from the National Health Service in Great Britain. In 2000, they changed their guidelines to recommend against what had been the routine practice in the past, which was prophylactic removal of pathology-free impacted third molars. About 12 years later, their incidence of dental caries associated with third molars had escalated over 200%, and extractions now exceed the 2000 level. And this is the kicker here for me, is the increased patient age is now 32 instead of 25. And so we know folks are taking longer to heal, have more complications, and they're losing their second molars with this too. Now that doesn't mean we then go revert back to all wisdom teeth are evil and need to come out. It just means we need to stick to what I'm starting to present here, where we take an evidence-based approach and an individualized approach to each patient. Additional indications would be associated cysts and tumors. And so not the most common complication of keeping your wisdom tooth, but but 3% in a large population like the United States is still a lot of folks. Curran et al. In 2002 looked at the incidence of cysts and tumors, the most common, other than the non-pathological, just follicular tissue, which is the most common, 67%, is the dentigerous cyst at 28%, and then it quite rapidly drifts off to KOT, which is 3%, and ameloblastoma is only 0.5%. So dentigerous cyst, like I was saying, what is the second most common odontogenic cyst after the periapical cyst? It's the most common neoplasm associated with impacted wisdom teeth. And so some of you might be wondering, when does a dental follicle become a dentigerous cyst? When do I need to be worried about that? You might see a Panorex with what looks like an enlarged follicle. Well, typically we're going to call it pathologic if it's greater than 2.5 to 3 millimeters. And treatment for dentigerous cysts, thankfully, is quite straightforward. It's extraction of the tooth and the associated cyst, and that's curative compared to some of the other cysts that are known for recurrence, like the OKC or KOT. And then I believe the last, or coming towards the last few indications here, resorption of adjacent tooth roots, especially if you catch it early before we're also having to extract the second molar, and planning for overlying prostheses. Generally, the textbook rule is we want 2 millimeters of bone over an impacted tooth. That's not black and white, though, either, especially if someone's very frail, lots of medical comorbidities. You know, if the tooth ends up needing to come out, they could still get it out, right, after the prosthesis is made. Let's talk about mandible fractures, because there's kind of two facets to this discussion. One is the presence of third molars increases your risk of mandible fracture, and quite a bit, 2.8 times the risk of your mandibular angle being fractured with the presence of a wisdom tooth. And then the other discussion is, well, what do you do with the wisdom tooth when you're repairing the fracture? Well, oftentimes, kind of like a keyhole, it helps, or a puzzle piece, it actually helps index the jaw back together, and if that's the case, you keep it. If it's in the way of the reduction, we'll remove it. If we did keep it, we can remove it later on after the fracture is healed. And then our last indication for surgically managing wisdom teeth is if it's currently non-functional or going to be non-functional. And so it's not unreasonable if, say you're taking out 17 because it's erupted and carious, to then also include 16, because it's going to be non-functional, and we can't, without our crystal balls, tell our patient that the tooth is for sure going to drift down or when it's going to, but we know it probably will, especially the younger the patient is. And so being non-functional is certainly an indication to remove them. It doesn't necessarily mean we remove 1 in 32, though, if there's no indication to remove them. But 16 certainly if we've extracted 17. Any questions about indications for removal? So let's touch on coronectomy, or that intentional partial removal, and why we would use this procedure. So coronectomy is a newer procedure, initially proposed in 1984. We still run into referring dentists who aren't familiar with that procedure, or why did those roots get left, or we hear. We try to communicate a little bit better with our intentions than that, but I've definitely heard other folks at meetings say that their dentists were wondering why the roots were left. And so we do need to always explain what we're doing and our treatment rationale to our patients and to our referrers. But it was proposed to reduce the risk of inferior alveolar nerve injury during removal. And that's a common problem with fully developed root systems in older patients. And so we know from looking at the data that the risk of inferior alveolar nerve injury after third molar removal ranges from 1 to 5% in the immediate period post-op. Thankfully, that shrinks down to less than 1% after 6 months. because most often these injuries are kind of bruising or bumping injuries, not necessarily transections. And we know that coronectomy reduces the risk of injury, but it doesn't eliminate it, and I'll show why on other slides. So what are some of the indications for coronectomy, or what increases risk of inferior alveolar nerve injury, rather, as a way? And one is looking at the Rude criteria, and that's this chart here. The A through D talks about root considerations, and then the bottom line, canal considerations. And so, and this is, of course, looking at a panorex. So when we're looking at a panorex and we see the apices in A are darkened, that's because there's less bone or no bone between the canal and the root. That's why it's darkened. Obviously, that means the nerve and the roots are in very close proximity, if not touching. Deflection, narrowing of the roots, a darkened bifid root. That basically means the nerve is flossing between the bifid root. And then the canal considerations, where we've lost our white line, so the entire length of the tooth is in close proximity to the nerve. Diversion of the canal, where the developing root literally pushed the canal out of the way. In a canal that was a little more stubborn, it decided to narrow instead of go out of the way. In addition to the Rude criteria being age over 25, less likely to recover from a nerve injury, and being female gender. So let's talk about advanced imaging and coronectomy treatment planning. So adding a third dimension provides additional information on root morphology and nerve positioning compared to two-dimensional panoramic radiograph. CBC has been shown helpful in increasing surgeon confidence in selecting extraction over coronectomy. So if I have a patient with a panorex that has one or multiple Rude criteria, I'm not needing a CBCT to tell me a coronectomy is potentially indicated on a 30-year-old. I'm going to do a coronectomy if the other criteria are met, and I'll go over that. But where cone beam is helpful is when maybe it doesn't meet the Rude criteria, but they look really close on the pan, or they look overlaid in 2 dimensions. But the cone beam will show me that it was actually like that in 3 dimensions. And so it therefore increased my confidence to proceed with extraction over coronectomy, because the nerve actually wasn't at high risk. And so CBCT is very helpful in our practice. And the data showed that if a surgeon looks just at the panoramic radiograph, 23% of them were making a coronectomy decision, and that dropped down to 14.5 after looking at a cone beam. And so an important thing to know about coronectomy is not every tooth is a candidate, right? So there's some considerations here that if you see a tooth that looks near the nerve, you're not going to be able to just tell them, oh, your surgeon's going to do a coronectomy there. Well, because there are reasons we don't. And in these situations, our current infection or carries into the nerve or pulp of the tooth. If the tooth is mobile, or if the root remnants are mobile, we're obligated to remove those because they'll get infected. And then in horizontal impactions, coronectomies aren't necessarily indicated either, because vertical sectioning of this crown here, my burr is right on the nerve still, therefore not modifying the risk there. So in those folks, like I did on Friday, I just told him, your nerve's at risk. And I think he was 32, but he had 10 millimeter probing depth on the distal of 31. Clear indications to have this tooth removed. But he and I both accepted he's at increased risk of inferior alveolar nerve injury. Just for curiosity's sake, the surgical technique, most importantly, we don't leave any enamel. Bone will not heal over enamel, but it'll heal over dentin. The residual root should be at least 3 millimeters below the crest of the alveolar crest, so that you can get adequate bony infill. And like I said, if the remaining roots are mobile, they must be removed. one thing all patients should know if a coronectomy is going to be offered or done is the potential need for a second surgery, and this occurs in about 5% of folks. It's not necessarily a bad thing, it's just they need to know that. And the most common reason, so half of these folks, so 2.5% of folks, are going to have that due to root migration or exposure of the root remnant later on, kind of like a splinter migrating through. And so late root migration occurs but is unpredictable. It's most likely to occur early on and more commonly in younger patients. In the past 2 years, I've had to remove one, and it followed this, a younger female patient with conical roots. But the good news is it always moves away from the nerve. So it's a second procedure with much fewer risks, much less invasive, and then has taken care of the problem. Sometimes you can develop an infection of the root even if it wasn't mobile, and that thankfully only happens in 10% of these folks that need a second surgery. Thankfully, the risk of infection isn't necessarily higher because you left the roots, and this is an area where coronectomy doesn't necessarily eliminate the risk of injury, because if I have to go in immediately after, maybe 2 or 3 weeks afterwards, to remove an infected tooth root, that nerve is still right next to the root, right? So that's now at risk. Sometimes due to pain, although quite frankly not that common. I don't necessarily get higher complaints of pain from my coronectomy patients. And then if you've left any residual enamel. This study was done in an academic center with residents, so a few of this can be contributed to the learning curve maybe. So let's talk, yeah. Yeah, so it stays vital. It stays vital because you didn't, because of the sectioning going back, and my desire to not mobilize or luxate those roots, because if I do, then I'm obligated to remove them. And so they still maintain their vascular and lymphatic flow, so the bone heals over it. The pain is surgical pain, and yeah, it's not necessarily the exposure of that. Yeah, and like I said, I haven't necessarily through my own eyes witnessed an increased risk of pain, and I have not had to remove remnant roots because of pain either. Although I know some that have. So anesthetic considerations, right? So we're talking about a little more invasive procedures here now, and many folks aren't going to want to necessarily do all of this awake. A lot of anesthetic options here for folks, and one thing I just want you to all be aware of too is that these options do vary. One, based off patient preference, the degree of surgical difficulty, and the patient's health status, specifically their ASA physical status classification. So try not to promise folks anything. That's really the point of the consult, because it will be up to me or the surgeon or anybody that you refer to determine what's appropriate given the practice setting and their health status. But our office-based options include local anesthesia with nitrous oxide, sedation, whether that be PO or IV. Some folks even have gas machines in their offices and can provide the same general anesthetic that is done in hospital-based centers. In addition, not all patients need to go to sleep in the hospital. Many of our cardiac valve patients that we'll take bad teeth out on before are too sick to have general anesthesia, and so they get a very expensive monitored anesthesia care with the anesthesia team more or less monitoring them, maybe with some light IV sedation and me giving local. And that's really one of the benefits that we bring to the table is, one, the provision of anesthesia services in the office-based setting, but then also being dentistry's connection to the hospital. and not saying that general dentists and pediatric dentists don't go to the hospital too, but to be board certified, you have to be in oral surgery, have to have hospital privileges. So a lot of oral surgeons have hospital privileges. So we can take care of the healthiest to the sickest. A little to touch on anesthesia safety now. So anytime you refer a patient to us, their safety is always our #1 priority. Office-based anesthesia has been part of the training, practice, and history of oral surgery for over 90 years. I'm sure you all learned in dental school too how anesthesia really started with dentistry, right? And nitrous oxide. Oral surgeons in their residency receive 5 dedicated months of anesthesia training. That's purely on the anesthesia service at a children's hospital and adult hospitals. And that's in addition to all of the remaining parts of their 4 to 6 year residency administering office-based anesthesia. Our surgeons at our practice undergo regular ACLS and PALS training, and all of our clinical support staff are required to be ACLS certified and DANCE certified, which is the AMIS Dental Anesthesia Assistant course. So safety is our #1 priority. So let's touch on post-operative management now. And so I generally will tell folks 3 to 5 days of recovery. It's not 3 to 5 days of bed rest, I'll say, but 3 to 5 days where you're not working out. If you have any school stuff to do, it's not writing papers or intense stuff like studying for exams. Pain management, generally I'll do, I follow a pain protocol where it's going to be over-the-counter extra strength Tylenol, ibuprofen on top, and a narcotic if needed for severe pain. Post-operative bleeding control, we tell folks they're going to bleed or ooze lightly for 12 to 24, even 48 hours. They're going to go home biting down on cotton gauze packs. Swelling is going to peak around day 2 or 3. I tell all my patients they're going to look like they have chipmunk cheeks. Because to folks that have never seen that before, that's really scary. Even if you've told them swelling's normal, if their kid looks like this, they're going to think something's wrong if you didn't really stress that point. And everyone's swelling varies. So peaking day 2 or 3, resolving by day 5 to 7. Post-operative trismus. So in incising your flap on the lower, you'll often go through the buccinator, which is not going to be comfortable to open all the way. Gentle mouth opening exercises improve that with time. Time heals most of these issues. And then diet modification. So I basically talk about soft foods advancing as tolerated and avoiding certain things like popcorn, seeds, chips, nuts, things like that. And then patients are going to go home with prescriptions, obviously. This will vary based off of the provider. Even in our practice, some things vary. But in general, they'll go home with pain medication, a varying course of antibiotics, chlorhexidine, for example. Now let's talk about postoperative complications. The #1 complication, thankfully, right, because this is an easy one, is food impaction. It's the most common source of postoperative pain and inflammation. And so we use a monoject syringe. Our practice gives every patient a monoject syringe to go home with. We didn't in residency, but folks would then come in with terrible taste, terrible smell. It's more common with mandibular molars, as you'd suspect with gravity. They're basically big shovels in the back of your mouth, just gobbling up everything. It's amazing what comes out of these sockets. And this can be prevented, or more likely, a better word is reduced, with daily use of an irrigating syringe after day 4 or 5. Earlier use can increase the next complication, which is the dreaded alveolar osteitis. Probably why many folks are keen to put off this surgery after you've recommended they have their wisdom teeth. There are many people I see that are like, oh, my dentist has been harping on me for the past 7 years to get my wisdom teeth out, and I finally did. I'm like, well, great. Now you're 27, and we could have removed these when you were 20. But I say that in my head. I don't say it out loud. And so again, thankfully pretty rare, incidence of 3 to 5%. We're very lucky that complications are quite minimal for this, more often than not an elective procedure. And so alveolar osteitis or dry sockets characterized by throbbing, radiating pain, bad smell, taste, usually beginning around day 3 or 5, right? And so it's based off symptoms. You can look, I can look directly in the mouth and see a socket that's completely void of blood clot, see bone, but if they're not having any symptoms, we're not calling it a dry socket.